So BitePACES course, yeah. I think there's a few spots left on the 3-day course. Feel free to scan the QR codes on the right to try and get onto the PACES course if you haven't done so already. And then also the WhatsApp group. Here's a QR code for joining the WhatsApp group. I'm sure many of you are already part of it, but if you're not, it's a great place for people to chat amongst themselves, find other people to maybe revise with or, do swaps with and so on and so forth. And also we'll be putting our updates and our webinars and all sorts of other things on there and handy tips and so on. So it's a great place to be if you're not already. The Bike Paces course has really good reviews. This is just a snapshot of Google reviews. Um, Everyone who's done it has had it's had overwhelmingly positive reviews. I can attest to this myself that when I teach on the course, everyone seems to go away from the day very pleased. So please do join if you haven't done so already. We've already done a few sessions. That was the pre-Christmas uh, sessions that we did, and then on this side of the new year, we've already done the common cases last week. Today we'll be doing com skills, and then tomorrow at 6 p.m. we'll be doing abdo as well with Pranish. So please do tune in for that as well. Finally, that's the same QR codes again. Please do scan them if you haven't done so already. Otherwise, I'm going to mute myself and I'm going to allow Abhishek to take over. And I'll be in the chat. Feel free to message, ask any questions as you go along, and I'll try and prompt them to Abhishek as we go, if necessary. Thank you, everyone, and yeah, enjoy.
Good evening, everyone, if you're in the UK, and maybe good morning to others if you are tuning in from around outside the UK. My name is Abhishek. I'm one of the registrars currently out of program. I'm a bowel transplant fellow at St. Mark's and Cambridge, and otherwise I'm an ST6 trainee at the moment, and one of the tutors at BitePACES since the last 2 years. I'm very delighted to share my experiences with you and give you some tips and tricks which increases your chances to succeed in the exam. I'll be going a little slow, but at the moment, I'm just going to get my slides up. So just let me put it up. Yeah, okay. Right here. Is everyone able to, let me just switch on the chat. Okay, perfect. Is everyone able to see the slides or see my screen? And am I audible to everyone? Perfect. Thank you. So, as I mentioned, today's webinar is mostly on communications, although what I have done is I've made a slide on medical ethics. This is a one slide presentation, but it's an integral part of the exam, especially if you are trying to navigate through the communication station, wherein I think you have got two communication stations now. So this most of your things would be based on a lot of ethics, and I think it's a good idea to just sort of run it through all of you. I'm very much aware that most of you might be already working in the NHS, so would be already familiar with these ethics or these ethical principles, shall I say. But if someone's being new and is very new to the way how NHS works, then this is going to be useful. Right. So, what I'm going to do, so as an international medical graduate and as someone who really struggled to present when I was preparing for the exam, because obviously my first language was not English, and I had faced a lot of challenges in terms of presenting myself. because I was able to design my thoughts, but struggled to deliver them properly. And even if I delivered them, I then realized that it was not creating that much of an impact, which it should have, because my chain of thoughts were pretty clear and organized. And then I realized that I need to practice more. And then I took some feedback to try help me sort out this issue. And during my first attempt in the PACES exam, where I was unsuccessful, you usually can get the feedback from the college after your results are declared. And one of the feedbacks in the communication station was that the presentation was not very impactful, or they were not organized properly. And that is where I realized that this is something that I need to work on. So I'm going to give you certain tips and tricks in terms of say how to present with maximum impact, and most importantly, structuring answers during the viva. So mainly in the clinical stations or in the clinical consultation stations, you would be at the end of your station asked, or at the end of your examination or the consultation, you would be asked questions, and one of them would be, please present your findings, or please, please explain what you have found. And it's very important that we structure it properly, because that will helps us in number one, saving time, avoiding listener fatigue, and number three, presenting it in a very structured way so that the questions are asked accordingly and you already have got the answers prepared. So you are literally playing a mind game with the examiners in terms of steering them towards what questions to ask you. And at the same time, you are already a step ahead of them because you already know what answers you're going to provide. Most of the time, it does work. Obviously, it all depends on how you're presenting it. I'm going to need some volunteers. And again, let me be very honest with you. I'm not going to be judgmental. I'm not going to be sort of, assessing any one of you. But these handpicked cases, the reason I need the volunteers is because it gives you the maximum benefit of it. And often after all the presentation is done, it's a, should I say, a good way to see how much what you have actually absorbed and get get into the field straight away. And final questions. So before I go to the next slide, can I have 5 volunteers, please? If there is anyone who is giving the exams very soon, this is an opportunity for you all to maybe give it a bit of a practice. Okay, what I'll do is I'll go through the slides just for the interest of time. But in the meantime, if any of you volunteer to practice it, it'll be great. And as I said, I promise I'm not going to judge anyone. I'm not going to give you any critical feedback. I'm just going to give you some fine tune your techniques if at all needed, because it might be that you have done a very good job. So no. All right. So before starting, so yeah, Dr. Patel, I don't need it just as now. Once I go through the slides, these slides will come. So uh, I will I will call you guys once you're there. But thanks for volunteering. So let me go through this carousel, and I'm sure most of you are familiar with it. And as you can see, you have got a lot of stations where you are actually then sort of assessed on, and communication plays a role in directly in four stations. So C, E, F, and G. Not only that, when you are actually speaking with the patient or you know presenting your findings to the patient, we can communications plays a very big role. So although it is your skills would be directly assessed in four stations, but almost in all the stations you would be benefiting from an improved communication skills. Now I'm going into medical ethics, and I'm again, as I said, like I'm pretty much sure most of you have worked in the UK or currently working in the UK are familiar with it. Uh, But for the benefit of the other listeners who have joined from around the world or are not particularly very familiar with the medical ethics in the UK, this is a small slide which I have created, and I'm just going to go through it. So, medical ethics over here, every ethical situation you can in real world and both in exam environments see things in these four categories. So one of them is autonomy, the other is beneficence, non-maleficence, and justice. Now, yeah, these things I'm given things which is like a bit more technical, but I'll break down the things for you. So say for example, autonomy. Let me give you an example. So say for example, you have a patient who is getting a lot of weight loss and has been having change in his bowel habits and a lot of heartburn. So, very naturally, your next thing would be if you are to investigate, your next thing would be to offer an upper GI endoscopy. Now, remember that upper GI endoscopy is an invasive procedure. So, for every invasive procedure, we need to consent the patients because besides benefits, there are risks. When you go through the benefits and the risks with the patient, upon hearing everything, they decide not to go ahead. Now, the challenge for you would be that you would not be able to give them a definitive diagnosis without doing an upper GI endoscopy, because you might argue that we might be able to do CT scans and stuff, but then CT scans are not going to pick up early cancers because you need a tissue diagnosis, which you are going to only get from an upper GI endoscopy where we're able to take biopsies. So, not going to the technicalities of it, but this patient can decide not to have this particular procedure if they are deemed to have capacity. Now, again, mental capacity is something that we assume patient has capacity if we are unable to demonstrate they do not have one. And capacity means they are able to understand the information, process the information, and then act on the information. So these are the three pillars on which medical capacity is based. So whatever you tell the patient, they understand it, they process it, and then they act on it. So when you are mentioning about the reason to do an upper GI endoscopy and the risks and benefits of it, they understand. And then they basically process what they think. Shall I go ahead for the benefits, understanding fully well what the risks are involved, or should I not go for it? Because that might mean that I'm not going to get the diagnosis, but I'm not going to be subjected to those risks. And then work on that information. So if those three there, then it's then established that the patient has got mental capacity and they can refuse. So the patient has the autonomy to take the decision to refuse your offered procedure, even though they're taking a wrong decision. So this is autonomy. Beneficence. Now, beneficence, a very easy way that I sort of explain to people is that, say, for example, you are working on a day shift, say an on-call shift from 9 till 9. Okay. And then your colleague's supposed to come and give an handover to you, and you're supposed to give an handover to your colleague and then leave. Now, at maybe 7:30, you suddenly get a text from your colleague saying that they are stuck in traffic, which was unexpected, and they would be an hour late. So beneficence is basically then you actually then and work till your colleague comes so that you're able to hand over safely. So this is both for the best interest for that person as well as for your patient, because your patient otherwise would, if you leave on time and then your colleague comes late on time, so that 1 hour, say for example, is hypothetically not covered for like patient care. So anything happens, who takes care? But again, these are all theoretical. Obviously, don't take it as something which happens regularly over here, because usually there are other people who sort of agree to cross cover. So most of the times, wherever I've worked, people are able to leave on time in 95% of the cases. Non-maleficence. So non-maleficence is, say, for example, you are a dermatologist, or you are basically, you have that technical expertise to diagnose skin conditions. Now you should be able to have the skills to be able to diagnose skin pathologies in people of all complexions. So in that way you are not what to say, you are not discriminating between different people. And the same for justice, that it also there's a bit of an overlap between the two, that you not only do justice to that person but also prevent your obligation to not to do harm, because obviously if you're not skilled enough, then you won't be able to pick that up. So this is in very roughly, I've just explained about the principles of medical ethics, but if you go online, there are lots of literatures with demonstrable examples for medical professionals. And then the more you do, the more you think along that way, the more easier it becomes. So let's start presentations. So impactful presentations. Now, what are what do you mean by impactful presentations? So I feel that when I actually worked on my presentations, there are a couple of things that I was being told, and then I reflected on that and implemented them into my day-to-day practice. They need to be sleek and to the point. You know what you're speaking about. You don't just start something and then you pause and then don't realize what you're going to say next. So you need to be very clear in your chain of thought as to what you need to tell them, and to the point, not too much and not too less. Okay. Positive findings. So whenever you're presenting a case, say for example in a clinical station or in a consultation station, you need to mention about the positive findings, and alongside that, relevant negative findings. Now, why have I particularly mentioned about relevant negative findings? Because what I usually see when I go to these courses, and I assess the candidates, and also like in my hospitals where I informally sort of help out or guide people, is that when they are presenting, they have gone through they have examined everything, but when they're presenting only positive findings. Yeah, it's very important to present positive findings, but at the same time, it is also important to also mention the relevant negative findings, because that helps to rule out certain differentials. Do not forget to include things by the bedside. So often what happens is, say for example, you are you are going to see a patient with, say, cystic fibrosis. Or let's make it very simple. Let's say you're going to see a patient in the respiratory station who has COPD. Now, when you are starting to present, often they start with, I've examined this patient and then this. But when you are either before the start of your presentation or during the presentation, if you scan the bedside properly, so patients with COPD often have sputum pots by the bedside. Same for the patients of bronchiectasis. So if you say, for example, if you're presenting to the examiner that I've examined this patient upon on auscultation, he has got has got bilateral crepitations on the lung bases, which displaces on coughing. He has a very chesty cough, and this is corroborated by the fact that he has got a sputum pod by the bedside. Makes your presentation much more impactful because that means that the examiner knows that you have observed properly, and these are brownie points. It is easy to get the pass mark, but it's more important to get the brownie points because that sort of helps you buffer if you have messed up any other station. Keep it crisp that there is time for questions because that is where you are marked on. Now, often what you will see is that people, when they are starting to present, if you have not practiced presentation well, then you will take up a lot of time. So you only get 4 or 5 minutes for questioning. So out of that, the examiner will give you the opportunity first to present. And then when you are presenting to the examiner, it is so when you're presenting to the examiner, I'm just trying to phrase it out. So when you're presenting to the examiner, you don't want to be too late or you don't want to cause listener fatigue. But at the same time, you want to say absolutely adequately and not less because then their questions will be framed accordingly. And as I said, it's all about playing the mind game with the examiner. You steered the examiner towards the question that you want them to ask you. And the moment you do that, you are then ahead of them because you've already thought about that answer that you want to give. And again, the other thing is that the more answers you are able to give, the more you give them opportunities to mark you. Whereas if you run out of time, they are not able to ask you the question, so they're completely judging you on your presentation skills. So give them lots of opportunities to mark you and to assess your knowledge. And complete the examinations with the relevant 10 sentences. Now, this is very important because, say, for example, you're doing an abdominal examination, you have said all your findings, inspection, palpation, percussion, auscultation, usual findings. And then what will happen is you need to complete by saying, I'd like to complete my examination by examining the inguinal lymph nodes, uh, hernial orifices, and a rectal examination. So these ones, these things are the relevant end sentences, and often I've seen people miss them out. And if you miss them out, maybe they'll deduct only a mark from your whole thing. But in these exams, particularly in the PACES exam, every mark is important. So make sure that when you rehearse with your practice partner, when you practice on patients, you always get into that habit of completing the presentation by the relevant end sentences. General etiquettes, again, you might question as to why I have particularly kept in the communication because there are two ways of communicating. One is your verbal communication and one is your non-verbal communications. So your etiquettes come under the non-verbal communication bits. So one of the common things that we do these days is do not this hang the stethoscope around our neck. Very common. A lot of people do it. But incidentally, I'm not saying fortunately or unfortunately, but incidentally, some of the PACES examiners are very senior consultants and could be old school, and they usually don't take it really well. I mean, they don't seem to think it as professional. So, say for example, if I am taking an exam, if I'm being an examiner during the actual PACES exam, I'm not going to mind much because I have sort of grown up doing this, but you never know what, or you don't have control on who would be examining you. So I think it is best practice to sort of not hang a steth around your neck. So your question might be, what do I do? in which case, what I tend to do is that I have this habit of moving hands. Again, this is something which certain examiners don't like. Don't ask me why, but these are exactly what I have been told. So what I used to do was I used to take the stat, get my hands around my back like this and hold the stat. That means that I'm not getting my hands to move and my stat's thrown around my neck. My hands are occupied, and you don't have to keep the stat anywhere else. Maintain eye contact with the examiner at all times. It shows your confidence and professionalism. So often I've seen that when people are presenting to me, they're looking at the floor or they're looking to the sides. No, this shows that your confidence is low. You can't afford to do that. You have to maintain eye contact with the examiner all times, because just think about it. Would you would you like anyone to speak to you without maintaining eye contact with you? I'm sure you won't. So the same thing about examiners. And do not look at the patient while presenting. You are given 6 minutes to examine the patient properly. So after that it is assumed, or it is expected, that within those 6 minutes you do not you need to look at the patient after that. You have seen everything that you need to do so that when you then present, you can actually maintain eye contact with the examiner. This is easier said than done, because 98% of the candidates that I assess, or during the course or in my hospitals, they tend to have this habit of looking at the patient while mentioning about the findings. So a good thing would be to actually present away from the patient or outside the patient room, because that will help you get into that habit of registering every examination findings in your brain, gains or organizing your chain of thought, and presenting to your practice partner and to the examiner during the exams. And speak at a moderate pace, not too fast, not too slow. If you speak too slow, then you actually risk running out of time, and then the examiner might not get the time to ask you enough questions to be able to mark you properly. Not too fast. Now, this is something that I have noted, especially if people are anxious. I mean, if any of you are taking the exams for the first time, this exam will incite a lot of anxiety in you. Even if I tell you that it's nothing to worry about, it's a very easy exam, then even then you will go there and the exam environment is going to make you anxious. And for people whose first language is not English, to be able to present and deliver your chain of thoughts in a language which is not your mother tongue, it is difficult. And often I've seen when people starting very fast presentation and then suddenly and then completely blanking out for a good 4, 5, 6, 7 seconds and completely losing their chain of thought. This happens when they speak too fast. So again, when you are practicing, not too fast, not too slow, but at a moderate pace, just so that the listener is able to actually hear what you are telling and organize in their brain as to what you are mentioning. Okay, this creates a big positive impact on them. As I mentioned, it gives you a greater opportunity. Now, what is the importance? Now, it gives you a greater opportunity to convey your thoughts. As I mentioned, you need to make sure that all the marking points are covered. So if you go into the MRCP official website, there are mark sheets. There are sample mark sheets where you can see your pointers or the things on which you are marked. Whenever you're practicing, always have that mark sheet with you. So if you have got a practice partner, whoever is actually sort of assessing you needs to be marking you on those, because at the end of the day, you are going to be marked on that. So it's important to base your preparations on those lines. Examiner fatigue. Now, some of you might question, well, we are studying, it's our exam, we have spent so much money, this is such an important part of our career. We should be getting fatigued. We should be we should be getting tired. The examiners are only coming here, listening to us, getting paid, getting a nice lunch, and going back. Why should they have fatigue? Trust me, I had the same question. But when I went to this other side, when you start with the first candidates, it's you start very enthusiastic. I'm going to listen a lot, but you only do these stations once, and then you probably your whole exam finishes within 1.5 to 2 hours. Your examiners would be doing it throughout the day, which would stretch to 8 to 9 hours. And trust me, this makes a massive difference because when they start hearing slow presentations and non-organized presentations, they actually is like, I can be least bothered. But they won't show that to you. So often they will miss out certain things which they are supposed to hear. And it's very human to do that. And outside the scope of your examinations, it's an important skill as you step up as a registrar and ultimately as a consultant. Because as a registrar, you would be expected to do a lot of referrals. You are expected to discuss scans with radiologists for vetting, speaking with microbiologists, presenting your cases to get their idea about antimicrobials. So again, as you present properly, it will sort of reflect in your development as a clinician. As a consultant, the consultants are mostly responsible in discussing their patients at the multidisciplinary team meetings or the MDT meetings that we call, wherein they are speaking with consultants across other hospitals, other specialties, and again, loads of cases are discussed on those days. It's very, very important and it reflects really well on you if you are presenting it in a very organized format and you just tell them the only the bits that they need to know so that you are able to get that information from them that would help your management of the patient. Now, all of this might sound overwhelming to you at this point, so I would not say to think till that, but the reason I mentioned is that your presentation skills, developing your presentation skills will not only help you for the exam, but also beyond that. Tips and tricks. So these are again, this is something that I have developed from my experience. Have a default framework in mind. So if it's one of the familiar cases, just fill in the blanks. What I often suggest to my juniors is that do a normal, examine a normal patient first, and then present the normal findings. And that way you develop a default framework at your spinal level. And when you are able to do that, it means that you don't spend time picking up abnormal things because you need to know the normal things to be able to pick up the abnormal. And number two is if you have got a very familiar case, say, for example, aortic stenosis in cardiology, interstitial lung disease in respiratory, kidney transplants in abdominal station, okay, so on and so forth. So if you make a default framework, so you know the findings what you will find in this patient. So practice accordingly. And say for example, you're going into the exam and you suddenly you hear an ejection systolic murmur, say for example, you more or less know that it's an aortic pathology that you are dealing with. So you know that um, there would be a slow rising pulse with a narrow pulse pressure, soft S2. Murmurs might radiate to the carotids if it's a very severe aortic stenosis. So you know which ones to look for. And number two is you then put it in your framework and you know, okay, I found this, I've not found this. So I'm just going to fill in the blanks in this framework and then present it to the examiner. It actually helps. It helped me massively. If you're very nervous, take a deep breath and then start rather than choking up in the middle, as I mentioned. Nerves will hit you. So, say for example, if you don't get a common case and you are not sure what the actual diagnosis is, you will start to feel nervous. Often, when the examiner asks you, okay, with a very flat face, without any emotions, okay, please present your findings. So, just take a deep breath. It's completely fine if you start 2 or 3 seconds later because everyone knows that you will be having that exam anxiety, and then slowly start to then achieve or slowly start to then reach your intended pace. Because if you suddenly start with being nervous and you literally start to, you will choke up in the middle. And I'm not joking, this has happened. I've seen people doing that. If you're unsure about the diagnosis, keep a list in mind about the positive and the relevant negative findings. So often it's very difficult, and again, giving the right diagnosis is a brownie point, but it's not the end of the world if you are not able to reach a diagnosis. So say for example there is a murmur which you are not, which when you're not particularly familiar with. So just keep a differential. You know that it's a systolic murmur. So give the differentials. So even if you don't get the full marks, you get most of the marks. You get what I'm saying? So rather than saying the diagnosis straight away, you give the positive and the negative findings. Now there is two schools of thought, and there is no right or wrong answer. Some people will ask you to say the diagnosis and then um, corroborate it with your positive and negative findings. Some people will say mention the findings first and then come to a diagnosis. Both have their pros and cons. To me, telling the diagnosis early, in the first, is a bit of a high risk thing, because often if you say the wrong diagnosis at the very beginning, then you are already saying it wrong. So even for myself, like personally, even when I knew that this is the case, I would just go through the findings, then mention my differentials, and then say, but keeping in mind all of these findings, my diagnosis is this, but my other differentials are this. The only exception that I say the diagnosis first is if people, or if the patient has a diagnosis of renal transplant and you say that this patient has got renal transplant. So why would someone get renal transplant? They would get a renal transplant because they have got an end stage kidney disease or a chronic kidney disease, stage 5. So I always say, okay, I have examined this patient, and this patient has got end stage renal failure or end stage kidney disease, as evidenced by the presence of this. There are scar marks which indicate previous hemodialysis through a vascath. There are maybe tunnel lines. You find the scars over there. If you find a fistula, you look at the fistula, whether it's active, whether you can actually auscultate the bruise, feel the thrill, see for needling marks, and you can say that, okay, this is a patient with renal transplant. Sorry, is a patient with end-stage renal disease with this findings. I can see a fistula which is active, but it's not being needled, but there is no evidence of any fluid overload, which means that this patient is a more definitive form of renal replacement, and that is in the form of a kidney transplant, as evidenced by the presence of a palpable mass in this particular place, and so on and so forth. You can also say that I could actually notice some mild tremors on the hands, that could be secondary to the immunosuppressive medications, likely the calcineurin inhibitors, namely tacrolimus or cyclosporin. Okay, so these days we use tacrolimus more. We don't use cyclosporin much. One of the questions that you might be asked is, why do we not use cyclosporin? So not want to deviate it from the fact, but this is the only case that I usually mention the diagnosis first. And this is particularly for candidates whose first language is not English. Practice in front of the mirror and with your colleagues who are local grads. Key over here is to be able to express your thoughts in English, because often you might be expressing your thoughts in 6 words, wherein there could be 1 or 2 words to explain it equally well. So I was very lucky to get a study partner who is a local graduate, and that made a massive difference to my preparation, because my first attempt I failed the communication station. My next attempt I got full marks in the communication station, and I would be lying if I say that I did it all by myself. My study partner, who's also a friend of mine now, they had a huge contribution towards this improvement. But again, as I said, like, if you don't get a local graduate or a local someone who is a native English speaker, it's not the end of the world. you can always practice well. Mastering the Viva. So from coming from presentations to the Viva, again, very common things. Your presentation would determine which questions would be fired at you. So you steer the examiner towards the questions that you want them to ask you. And most commonly, the first question after your presentation would be, okay, so what are your differentials, or how do you want to manage the patient? So you are already, so this would be the default questions. There would be nothing else. The only difference that the examiners can actually tell you is that, okay, just tell me the positive findings. I don't want to hear anything, just tell me the positive findings. But in 97, 98% of the cases, it would be, what are your differentials, or how do you want to manage the patient? Always start, when you are doing a clinical examination station, a very good way to get a brownie point is when they say, how would you want to manage the patient? I'll just say, I would like to take a full history from the patient. That shows your awareness. That shows that you are not here just mugging up things. Because think about it, in the real world, if you are presenting a patient for your post-take ward round, or say, for example, seeing a patient for the first time, you would take a history first, isn't it? Before going into any diagnosis. Your examinations sort of help establish your history. So if you tell this thing to the examiner that I would like to begin by taking a full history from the patient and then corroborating that with my examination findings, you have already created a very positive impression on the examiner's mind, because they know that you have been doing it day in, day out. So it's a very good tip to keep in mind. Divide your investigations. So when you're going into the investigations bit, divide your investigations into bedside ones, bloods, imaging, and then go into the more advanced ones. And if you ask me, do you have to always do this in the exam? Well, I would say it's not mandatory, but if you do that, it is easier for you to, number one, remember it, and number two, again, show to the examiner that you have a clear chain of thought and that you are someone who has not mugged up things, but who is pretty much experienced in what they do in the day-to-day interaction with the patients. So bedside ones, you do the observations, you do blood sugar measurement, you do an ECG, you do an A2E examination. So that's bedside ones. Then you go for the bloods, including a VBG. Then you just send them for a chest X-ray, and then to more advanced ones, like if you want to go for endoscopy or maybe a CT, or go for a nerve conduction test or an echocardiography, depending on which patient that is. And when you're going into a treatment section, or like managing the patient after investigation, I was told, and the examiners here absolutely love to hear, that I would like to adopt an MDT approach to treat the patient. And I would want to divide the management into pharmacological management and non-pharmacological management. So say, for example, you are say presenting a patient with, say, COPD. So you know the medical management, and the non-pharmacological management, you can always say, I'm going to offer smoking cessation advice. I'm going to assess the need for chest physiotherapy. I'm going to speak with our our COPD or respiratory nurses to give them a proper lifestyle advice, so on and so forth. So these things you would be doing on a day-to-day basis. So my objective here is to sort of pass on this message to you, that whatever you do or whatever you see on a day-to-day life as a doctor in the NHS, just reciprocate that. Show it to the examiner that you do this day in and day out, and that you would make a very good registrar when you clear this exam. That is what they want. They want safe doctors, and uh, they want people who are able to do the things in a way that they can they can assign that responsibility to you, and with a lot of reassurance. Again, same thing as I said for presentation. So speak at a moderate pace and clearly. If you do not know the answer, say it with apologies. So I'm really sorry, I'm not sure about that answer, but I'll in an ideal world, I'll look that up. Or just say, I'm sorry, I do not know that. Because what happens is that then the examiner will switch on to a different question, and that gives them a chance to mark you on a different way. but don't make it a habit because obviously you cannot miss out normal things. Do not appear arrogant. Now, often, uh, again, I don't see it very commonly, but I have come across certain people who are, oh, I mean, bless them, they're very experienced, but that experience should come up as a confidence and not an arrogance. Okay. And most importantly, say a thank you at the end of the viva. So as soon as the bell rings and the examiner says, okay, that's it, thank you. As you finish examining the patient, thank you. So this again helps you gain the marks from the communication bits. So some examples, this is where we need the volunteers. And again, we would be able to make it much more beneficial if we have volunteers. So Dr. Patel has volunteered to do the first one. So what I'll do is I will, so Dr. Patel, you can unmute yourself.
Yes.
Great. So thanks for volunteering. So what I'll do is, so this is a diagnosis that you know. So say, for example, you are in the cardio station. You have deduced that this patient has got aortic stenosis, and these are your findings. Okay. I'm giving you 1 to 2 minutes time, 1 minute time. Just prepare a presentation format and you can present to me.
Male or female age?
Um, let's say female, 68 years of age.
Okay. Okay, if I can start.
Okay, perfect. So go ahead.
I was asked to examine the 68-year-old female patient with regards to breathlessness. On general inspection, the patient does look slightly breathless at rest. Looking on the bedside, do not see any bedside medications, any telemetry, any supplemental oxygenation, or any walking assistant devices. On closer inspection, I noted that the patient has a pulse that is weak and seems to be slow rising. Furthermore, on expect review of that aspect of the chest, I could not feel any sort of thrills or heaves. On auscultation of the heart, I noted that there was a systolic murmur that was loudest in the right second intercostal space, uh, uh, and it seemed to be going along with the pulse, suggesting it was the systolic murmur. Furthermore, it radiated to the carotids and it had a second heart sound. Putting all of these findings, additionally, there was no peripheral stigmata of infective endocarditis or any signs of fluid overload. Putting all of these findings together, I believe my patient has systolic murmur. My primary differential in this case would be aortic stenosis. My other differentials would be aortic sclerosis. However, that would not radiate to the carotids. And additionally, potentially a flow murmur or even hypertrophic obstructive cardiomyopathy. In this case, with regards to the aortic stenosis, as the patient is breathless, I consider that the patient has a severe form of aortic stenosis. I would like to initiate my examination by taking a full history from the patient, getting a bedside ECG, and getting an ABG as the patient is breathless to rule out any sort of respiratory cause. Furthermore, I would also want to go from there and get a full blood count, CRP, to rule out any sort of infection or any anemia, as potentially of the flow murmur could potentially be caused by anemia. Furthermore, I would also want to get U&Es and LFTs as to establish a baseline in case there's any complications further along the patient's hospital stay, and furthermore, get a coagulation profile in case the patient will require anticoagulation at any point. Aside from the ECG, I would like to get a chest X-ray to rule out any sort of calcified valve, and also get ultimately an echocardiogram looking for the narrowing or the mean valve gradient to be more than 40 millimeters of mercury and a valve area that's less than 1 centimeter squared. And also look for any signs of the aspect of the patient having any left ventricular ejection problem, fraction problems. Furthermore, I would also consider in this patient to get exercise tolerance test to consider the patient for angiogram and see if they would also qualify for a coronary artery bypass graft. Ultimately, the patient will be in need to be discussed in a multidisciplinary team with the cardiology team and potentially even the cardiothoracic team, as is this patient seems to have severe aortic stenosis. I would like to discuss with them to see if, based on the patient's age and as per taking the history of their comorbidity, if they would satisfy a surgical or a venous or a transcatheter aortic valve replacement approach. And also, ultimately, at some point, also discuss physical therapy and occupational therapy with the patient thereafter and cardiac rehab.
Okay. Right. Great. Excellent. I think you have rehearsed this case very well because you know most of the things. So yeah, it's very well presented. Um, Not much of recommendation to give. I think I'll just tell you two things. So number one, whatever you have said is basically all the questions that would be asked to you. So I would say, give the examiner a bit of opportunity to ask you those questions because I'm sure you will do that in the examination. So when in your initial present, when you are just presenting the patient, I would just end it at hypertrophic obstructive cardiomyopathy because then you went on to the investigations bit. uh, I would prefer personally that you then, as I said, you have already steered the examiner to ask you the next thing. So the moment you say the differentials and you stop there, the next question would invariably be, okay, how would you want to diagnose or how would you want to investigate, or if they can even say, how do you want to manage the patient? And then you go on with the other things. But
Yes, sir.
but otherwise, again, if you're just presenting, just stop at the differentials, just stop at the HOCM when you mentioned. The other thing, again, you might consider implementing it, is that I usually, when I started, I said, I've examined this patient and they look um, comfortable at rest or breathless at rest. Again, this is something that you can incorporate because it's a very easy thing to observe, and often when you say the first one or two sentences, often that it helps to ease the nerves in the exam.
Yes, sir. Thank you
Okay,
so much.
no worries, but otherwise really well presented. And yeah, I mean, this is what other people should try to be like.
I think the only thing I forgot to mention was the causes, but aside from that, yeah.
Okay, yeah, this will happen. So that's the thing. So this is where practice comes into play because the more you do, the less you stand to miss these things. Because the moment you go out of the room and you sort of, oh crap, I have missed this thing, and that sort of plays in your mind all the time, and that might potentially affect your next station.
Yes, sir.
Okay,
Thank you.
but well done. Okay, do we have any further volunteers? Or if Dr. Patel, you want to do more? I'm not going to force you to do because I already done one, but it's up to you or up to others. So this is an opportunity to actually, practice things because the more you do practically, it is then easier for you to reflect on. Anyone?
Sir, if no one does it, would it be okay if I do it?
Yeah, yeah, go ahead, go ahead. Absolutely, more
Um,
than welcome.
is it can I know the age
Yeah,
and
yeah, sure. So
the
this is a 40-year-old male.
okay, and
Yeah.
is the crackles are both at the top of the lungs and bottom?
Yeah, you can present as and how you want to. So I've just given you the findings.
Okay, okay,
Just frame it
that's all.
accordingly.
Okay. I was asked to examine this 40-year-old male who presented with difficulty breathing. On general inspection at the bedside, it did not see any sputum pod. I did not see any supplemental oxygenation or any sort of telemetry or walking assistant devices. On closer inspection, I noted that the patient was comfortable at rest. On closer examination, I noted that the patient had a clubbing of the fingers, Furthermore, I noticed that there was with regards to auscultating for the patient's lungs, I noted there was fine and inspiratory crackles at the bases of the lungs, and the patient had a dry cough, and there was decreased vocal resonance. I did not appreciate any peripheral signs of pulmonary hypertension or cor pulmonale or any signs of fluid overload. There was no change in the patient's crackles upon the cough test. And putting all of these findings together, I believe that my patient has pulmonary fibrosis. More likely that it is. I did not appreciate any signs of any rheumatoid changes in the hands, any signs of any sort of stroke-like features to consider aspiration, or like to look into other things to in this case. And ultimately, my primary differential in this case would be idiopathic pulmonary fibrosis. And I would like to start off by taking a full history from the patient. I would like to get an ABG at the bedside to determine the type of respiratory failure and get if from there, I would like to get full blood counts, CRP to rule out any infection, using these as well. LFTs in terms of determining any complications and coagulation profile. Furthermore, I would like to get in this patient's case autoimmune screen, more specifically a rheumatoid factor and anti-CCP. Additionally, I would like to get the aspect of lipid profile and assess if there's any sort of raised cholesterol to assess potential for stroke. Furthermore, I would also want to look over the patient's, go from there and get a head CT for the patient, and ultimately the patient will require chest X-ray to see if there's any sort of reticular nodular changes, and ultimately a high resolution CT scan looking for any subpleural honeycombing, the bibasillary, or any sort of ground glass opacifications throughout the lungs. Yeah.
Yeah, good, good. Yeah, again, really well done, excellently done. And
Hey,
yeah, it's just that go through your investigations once you're asked that question. So it just
okay.
gives you that opportunity to for that examiner to ask you the questions. Because
Okay.
otherwise what happens is say for example if your exam is towards the second half of the day, and
Mhm.
also then there is a realistic chance of listener fatigue in the
I
examiner.
see. Okay.
So just try to keep it short and crisp, and then they can go through the thing. So they have their own like frame of questions. So present your findings, how you're going to manage, what are the most common causes of interstitial lung disease, what are
I
the
see.
treatments of it, so on and so forth. Okay.
Mm.
All right. Well done. Great. So I had three more cases. So I'm considering no one else has volunteered, and I'm not going to I'm not going to torture you again, Dr. Patel. You've done like two already. So these are common cases that I've actually put up. So yeah, I suppose that is that is the whole thing. That is the whole presentation from my side, and I'm happy to take questions. Any questions?
I think somebody put in the chat, when asked, present your case, would we go through each step like inspection, palpation?
Okay, yeah. So you can, if that helps you to organize your thoughts well. There is absolutely nothing wrong in doing that. So yes, you can do that. How do we make it crisp by being brief? Um, Crispness is, again, it is once you get the diagnosis and you have examined the patient, you know the relevant positive findings, you know the relevant negative findings, and yeah, it's a misconception when people think that being crisp means that you need to be brief. That's not correct. You need to say the adequate amount. And I would say when Dr. Patel, how he presented the two cases, that is what we mean by a crisp presentation. But yes, it'll come with practice. There is no right or wrong way. The more you practice, the more you present during your post-take ward rounds, the more you present to the consultants, the more you, say, for example, say do the referrals to other specialties. That's how you develop that crispness, because then you actually get to know, okay, this is what I need to say, this is what I can avoid. Yeah. Any more questions? So I think overall, this topic is nothing which will increase your knowledge about any sort of clinical presentations or anything, but as you can understand, it is an integral part of the exam, and often people do, struggle with this. And it's not their fault. It's purely because this exam desires, like, expects things in a certain way, and it's useful to know exactly or have an idea about how to go about with things. Okay, Miller, are you still there? Are we supposed to greet the examiners? Um, Good question. No one will take it against you, but you can always say a good morning. It's just courteous. People love to be treated with courtesy. I'm sure you would be too. So yeah, there is no, I mean, it's always good, but again, if you don't do that, it's not going to be taken against you, because examiners do realize that you will be in a lot of exam anxiety, and yeah, it's not going to be taken against you if you don't. But definitely greet the patient like, hello, morning, my name is Dr. This, doctor surname, and I'm going to examine your respiratory system, or I'm going to examine your cardiac system, examine your heart, or your cardiac system, which involves examining your heart, your legs, your face, listening to your lungs. Before that, are you in any kind of pain? That's usually the default way of starting a conversation with the patient. All the best to you, Dr. Patel. Thanks for participating again, and to all of you who have their exams coming up. And I would sort of reiterate what Milad said in the beginning of the webinar today. So definitely do sign up for our courses. Um, I would definitely say a lot of we have a lot of positive feedback from a lot of candidates who have taken this course. So yes, you will definitely benefit from it. If you're coming, whoever is coming for the next course, I would see you there.
Yeah, thank you everyone for attending. Really good to see you all. And That was a fantastic presentation, Abhishek.